playing a very good role in this area. And our great success is that in Bangladesh, already it has been scaled up. From 2008, from this year to June probably, we prepared 8 books, but now 1 book, 3, 4, 5 book will be distributed all over the country in primary education. So it is a great success for Bangladesh and this project I can say. Okay, I can conclude in this way. Childhood burn is really a big problem, but it is preventable and with low cost. And it is tested. I didn't put the evaluation report here, but we found that drastic reduction of, because we couldn't analyze the minor burn, hospitalization rate significantly reduced. Thank you.
Thank you, Dr. Mashaki, for your nice presentation. Now it is question and answer session for Dr. Mashaki. Anybody have any question, please?
My question is about the length of stay with hospitalization. You said for the severe case it's 28 for some days, but it is for the first phase treatment. And whether you have any idea about whether the first phase treatment was successful or how done, because our experience is many times they are leaving the hospital.
Actually, I'm all of data is there. It is not. It is from the household level. So we just ask them how many days you spend in the hospital. So these were actually calculated. So we didn't have the other background information.
And you haven't asked how many times they have to get admitted in the hospital?
No, that question was not there. That's how many days you spend.
First question is, what is the area of 8 lakh people in what district?
It is in Raiganj Upazila in Sirajganj, Monopudi Upazila of Narshangi, Sherpur, Shodor Upazila in Sherpur, and Mirpur in urban area, Mirpur in Sri Lanka.
Is there in any possible musical sound making instrument toddler?
Yeah, yeah, we introduced it first, but now people actually don't like it because they see some allergic manifestation there. They say that when they sleep, sometimes hurt there. So it is not very popular. We started to track down how children use, but it is in our finding it is not very acceptable to the community.
Next speaker is Dr. Shobha Chamania. He will speak on burn prevention and advocacy in Indian perspective.
I'm going to share my experience on burn prevention and advocacy in India. Dr. Mashaki and my previous speakers have actually laid the ground as to why it is important that we should be preventing the burns. And since morning we've been talking on this, that prevention is the best thing for our countries. Because it is the developed world that has shown that they are reducing the incidence, and we are still not making a very significant dent on the incidence. And in India, we don't have a twin of Dr. Mashaki, and so we still don't have any concrete data. You're fortunate to have data. And so we use only hospital data, but that is good enough for us to know what is the main problem and what should be focused for preventing planning. And these data must be told to the policymakers and to other groups for their active participation in burn prevention. The objective is three-pronged prevention. It is not only to reduce incidence, which is primary prevention, but we should focus to reducing the severity of burn, which is secondary prevention, by educating people on how to extinguish fire and how to do the best first aid. And the tertiary prevention, which is a very important part, is that you must give appropriate treatment so that the patient is treated quickly and the complications are prevented. There are methods of preventing, active and passive. Active is by increasing awareness, which includes all kinds of educational material. And passive is, like Dr. Mashreki said, that you can construct something that sort of prevents the child from entering into a dangerous zone. So those interventions are very useful. And legislations and design modifications are also some of the examples that we can talk about shortly. Education has proven to change the behavior only in 13% of patients in one of the reports published by McLaughlin, but Dr. Keswani has proved that it has significantly changed the behavior because the school children, like Dr. Mashreki has mentioned, that school children come and tell the mother to change the behavior at home, and in the developing world this is helping quite a lot. And we are conducting even in community and using all the timings like vaccination, health checkups, healthcare visits, where actually a healthcare worker comes in contact with lay public. So we are targeting adults and children both. We also celebrate 1 week of fire prevention, and we hope to celebrate a World One Day doing the same activity. India is fortunate that the days of Bubi would be over for them very shortly, as we had solar lamp now. These are the posters that we use. One of them for fireworks, because we have a lot of Diwali birds, that we encourage them to use a firecracker for igniting from a distance from their body using a stick, so that even if it explodes, it doesn't burn the person. We encourage wearing apron to tie the loose ends of their garments, and for the child to be supervised in big functions where hot cooked food is kept at ground level, and usually these children playing around that fall into those vessels and sustain dorsal gluteal burns. This is the solar lamp, which has been the research of Indian design makers, and I think Bangladesh should take this. The brown one is a Chinese lamp, and the blue one is Kiran. It is called as Kiran, and it's a Government of India propagation in the rural area. And this has come under a national program for replacing all the Bubi batis and supplying Kiran solar lamp there, which does not require any maintenance cost, and its batteries are charged free with solar light. Since we are the blessed countries with solar energy for 365 days in a year, I think it is time for us to share this knowledge across the border.